Hello everyone, this is Dr. Cristian Spanish Schmidt from the Danbury Hospital. This is the case study for the week. This is POCUS Bites, and I have a great case presentation for you guys. This is a 41-year-old man who was brought to the hospital because of seizures. The patient had one seizure at home and fell. That was witnessed by the wife, and one at the hospital while the patient was going to CAT scan. He has a history of seizures, and for that, he takes some levetiracetam. Also has history of bicuspid aortic valve, which he never took care of. Um, in the ED, he was started on levetiracetam IV, and at that moment, he was found hypoxemic and started on broad-spectrum antibiotics and furosemide. A chest X-ray and an EKG is as follows. So here we have a chest X-ray that demonstrates, well, it's an anteroposterior, but however, you can see some cardiomegaly. There is increase of the iliac markings, and there is definitely air space disease with air bronchograms, likely with some pulmonary edema. They didn't want to do the distinction between the presence of a right lobe pneumonia at that time. So an EKG was performed or taken, and it demonstrates left ventricular hypertrophy by Sokolov-Lyon and other criteria. Um, the patient also is in sinus rhythm with sinus tachycardia at the moment of the EKG. You can see that it has biatrial enlargement, and there's T-wave inversions in 1, VL, and V6, likely secondary to left ventricular hypertrophy, but we cannot really rule out ischemia at that moment. We didn't have cardiac markers or a BNP at that moment. At the moment of my evaluation, there was a mild leukocytosis of 11,000 with left shift. Everything else was normal. I didn't have any other tests available. We went to the patient, and the patient was lying down at 30 degrees, not in acute distress. The O2 sat was 95 on 2 liters. It was documented 88% at room air before the O2 was started. Important, the patient was alert, oriented, awake, and he was very cooperative. Vital signs were essentially normal except for a respiratory rate of 25, and that the patient was with some oxygen. He did not remember either episode of seizure. As I said, the seizures were witnessed by the wife and the people in the hospital and were described as tonic-clonic. Uh, Findings in the physical examination were non-existent, and he had mild crackles on the right base. So a long ultrasound was performed, and here we can see, I'm gonna describe the structures again for you guys. This is the pleura, which looks normal and moving fine or sliding fine. This is the periosteum of the rib. So we are right in the middle of two ribs with our guide towards the head of the patient. This is zone 2 as per Volpicelli 2012. This is my preferred method. This is 1, 2, 3 B lines. So we can say that this quadrant on the right side was positive for B lines. And here we have the acoustic shadow from the rib. You can see the same thing in the other side. So here we have zone 4, and you can see the curtain sign. Sometimes this sign is not mentioned a lot, but sh- shows that you have a normal lung basically, and there is no pleural effusion. So you can see the curtain sign, and there is a line. So at that specific quadrant, the patient did not have signs of pulmonary edema. Then we went to the other side, and in the other side, he had more zones like this. I'm not going to show everything, but this is zone 5, and what I'm seeing here, you know now the structures. You can see that there are no A lines, and basically this is a white lung, I believe, secondary to some pulmonary edema. Remember that the patient already had some Lasix when we saw him. Here, it's a cardiac ultrasound, a focused cardiac ultrasound, and I just want to make a disclaimer. I made this one with the machine, the Sonosite downstairs in the ED. It's a new machine for me, so I don't know all the functionalities, but ED machines usually use um, the same orientation for heart than in abdomen. That's just what the way the does things. So that's why we are seeing that despite the patient, the echo, or I mean the ultrasound being in cardiac mode, you don't see it change. So what we see here, basically, I'm going to describe. It's a very hypokinetic left ventricle. You can see this is the left ventricle, and the walls of the left ventricle look hypertrophy, although I didn't measure them. Um, you can see the anterior leaflet of the mitral valve right there, and it is not going near the septum. You want the mitral valve to go when it is opening almost to the septum, less than zero point 0.8 centimeters, to say that you may have a normal ejection fraction. You can see the RV here, which is also hypokinetic to my eye. This is the pericardium, which doesn't have any fluid. And this is the aorta. It's interesting that despite this is a good view, I cannot see a normal aorta, and this is because the patient has a bicuspid aorta. I did not measure the aorta per se, but just comparing with the ruler that we have towards the right of the slide, you can see that it's less than half centimeters in that view. So here we are evaluating the ejection fraction via the movement of the anterior leaflet of the mitral valve. So that line that I'm showing you, it's in M mode, and you can see the guide of the M mode, and you can see that the mitral valve basically is barely moving. This is the LV cavity, which is also barely contracting. This is the septum, and here is the best that the mitral valve can do in that view. You can see that goes beyond 1 centimeter. So it's more than 0.8 centimeters. So likely the ejection fraction is decreased. So here we have a short axis. I just took one picture. Remember, this is a focused ultrasound, not a complete echo. And you can see that this is the left ventricle, and it doesn't seem to be squeezing blood normally. You can see the endomyocardium, and likely the whole ventricular dysfunction. I mean, the whole ventricle is dysfunctional. You also can see that there is no pericardial effusion. This is a very nice view, and I'm very happy I was able to take it because I was trying to figure out if this aorta, and first the left ventricle, you see it's dilated and hypokinetic. We cannot see really well the endomyocardium in this view, but we can see definitely that it's dilated and hypokinetic. and the movement of the anterior leaflet of the mitral valve is poor. The right ventricle, same, is hypokinetic. I cannot say if it is dilated or not. The left atrium to my eye looks dilated, and the right atrium also looks dilated. In the center, we have the aorta, and probably for you didn't look like normal, like what they call the Mercedes-Benz sign, because there is no Mercedes-Benz sign. This is a bicuspid aorta. So this is the aorta. This is a bicuspid aorta. And as you can see, if you compare to the scale that is on the right, it's probably less than half centimeter tops, half centimeter. Here is another 5-chamber view, a little bit different angle. I just wanted to confirm my findings. Again, a very akinetic and dyskinetic left ventricle. Again, the right ventricle not contracting well. You can see the mitral valve gives you the money. There is no movement of the mitral valve. There is not normal. The left atrium seems dilated again. The right atrium, and again we have a bicuspid aorta right in the middle. This has really big implications for treatment. We basically based our treatment that night based on this ultrasound. And this is from this is a subcostal view. Again, in the ED, despite you being using a cardiac window, the machines will not turn the imaging for you. It's just the way the ED works. Again, the LV. This is the lever. We are using the lever as a acoustic window. This is the right atrium. This is the left atrium. And then this is a mitral valve, which is barely moving, as I said before. So this patient has global uh, decrease of ejection fraction and decrease of the ventricular function. This one is a little bit better, and you can see that the thickness of the left ventricle looks pretty fine. This is the mitral valve, barely moving. Here we have the cavity of the left ventricle. This is the right ventricle. This is the right atrium. And now you're gonna see something really cool. Whenever the shadow, the acoustic shadow doesn't appear, this is the aorta. So there is an acoustic shadow that appears and erases like a curtain again. This is when the patient breathes. But this is actually the aorta trying to open. So we knew that this patient had a very tight aorta at that moment. And again, the pericardium, these comets that you see from the pericardium are normal. So the inferior vena cava, in this case, we measure it at where the hepatic veins uh, get into the vena, the inferior vena cava here, and it's collapsing. I didn't measure it, but to me it looks fine. And we did a neck ultrasound at 30 degrees, and you can see this is the IC, and there is a pulsatile IJ not fully collapsing, and likely this patient is a little bit still on the hypervolemic side. So because of this, we change the management of this patient, and we start him on low dose of diuretics instead of higher dose of diuretics because the patient is basically volume dependent with such a tight aorta. An echocardiogram that was performed the next day confirmed all our findings, and the patient also ended up in cardiac cath. The cardiac cath showed normal coronary arteries, and we believe this is all secondary to the aortic valve, which had 0.04 centimeters of area. So the patient will have a aortic valve replacement. So this is a beautiful point of care ultrasound for you guys. Remember always to have a question. What are you asking? What is your concern? And make the right diagnostic ultrasound for the question you have. And always, if you don't get your imaging, just say, I did not get my imaging. Thank you again.